Welcome to Bookfulness. This is episode 35 in our deep dive series, working our way through clinically oriented anatomy.
That's right. We spent quite a bit of time recently really deep in the head, haven't we? Covered the cranial base, the orbit, intricate stuff.
Definitely.
Yeah.
But today we're shifting just a little bit, kind of moving down into the areas responsible for, well, really basic things we do every day: chewing, talking, even facial expressions.
Exactly. We're focusing on the content around Chapter 8 in the source text.
Yeah.
It moves us from those big bony structures we talked about into the more, let's say, functional parts of the face and the mouth.
Right. And the goal today, our mission, if you like, is to really unpack the anatomy that lets us chew our food and form words, but also crucially to highlight the clinical side of things. It's amazing how many potential problems are packed into such a small space.
It really is. I mean, you've got major nerves, blood vessels, glands, all crammed into these quite confined bony areas. Think about the infratemporal fossa, for example. It's incredibly efficient anatomically, but that efficiency, well, it comes with certain mechanical and clinical risks, as we'll see.
Okay, so let's start this exploration, maybe laterally and superficially first, with the parotid region. The parotid gland itself is quite something. It's the biggest of the three main salivary glands, right? Tucked in right near the ear.
Yes, it occupies this really important space. If you look at a cross-section, it's sort of triangular. It's nestled between the ramus of the mandible, that's the upright part of your lower jaw anteriorly, and the mastoid process of the temporal bone posteriorly.
Okay.
But the key thing, especially clinically, isn't just the gland itself. It's what passes through it or is embedded within it.
Ah, right. It's like a major intersection. What kind of structures are we talking about?
Well, critically, the facial nerve, CNZ7, it emerges and then branches out within the gland substance.
To supply all those muscles we use for expressions, right? Smiling, frowning.
Exactly. All of them. And you've also got the retromandibular vein running through there and the external carotid artery, which branches within the gland too.
Wow. So the facial nerve forms a network right inside the gland.
It does, called the parotid plexus. And you can immediately see the clinical implication, can't you?
Surgery.
Surgery. If you need to remove a tumor from the parotid gland, which does happen, the risk of damaging those fine branches of the facial nerve is incredibly high.
Leading to facial paralysis, potentially permanent.
Precisely. Surgeons have to be meticulous, identifying the main trunk of the nerve before they start removing glandular tissue. It's very delicate work.
That risk really underscores the complexity. And you mentioned something else related to infections. That makes problems here particularly nasty for the patient, the parotid sheath.
Yes, the parotid sheath. It's part of the deep cervical fascia, the investing layer, and it forms this really tough, unyielding capsule around the gland.
Unyielding is the key word there, I guess.
Absolutely, it doesn't stretch. So imagine the gland swells up, maybe due to mumps, parotiditis, or some other infection.
Okay.
The gland gets bigger, but the sheath won't give way. It resists that expansion.
Which must cause incredible pressure.
Exactly, excruciating pain, because the gland tissue itself is being compressed, and crucially, the sensory nerves passing through or near the gland, like the great auricular nerve, the auriculotemporal nerve, they get squeezed hard.
So the pain isn't just from the swelling, it's from the nerve compression against that rigid fascia.
That's a huge part of it, and it's a perfect example of anatomy directly influencing the symptoms, the pathology.
And that pain can sometimes be confusing. I think the text mentioned it can feel like a toothache.
It can, yes, because the nerve pathways, particularly the auriculotemporal nerve, which also has connections related to the lower jaw, can refer pain. So the brain sometimes misinterprets the source. It highlights how interconnected the sensory innervation is in this whole region.
Okay. Now, if we move a bit deeper and maybe slightly superiorly from the parotid gland, we get into the temporal and infratemporal fossa?
Right. These are distinct spaces defined by specific bony landmarks. They basically act as the deep corridors for the major nerves and blood vessels supplying the jaw muscles and deeper facial structures.
The temporal fossa is the more superficial one, right? Above the cheekbone arch.
Correct. Superior to the zygomatic arch, you can feel it on the side of your head. It mainly houses the large temporalis muscle, which is one of our key chewing muscles.
And then deeper than that, tucked behind the jaw ramus and below the zygomatic arch, is the infratemporal fossa. That sounds like the really complex area.
It really is the anatomical hub, or maybe the basement, as you put it. It's packed.
What's in there?
You've got the other main muscles of mastication, the medial and lateral pterygoids. You've got the mandibular division of the trigeminal nerve, that's CNV3, the chordotympani nerve carrying taste fibers, the autoganglion, part of the autonomic system, and the very large maxillary artery and its branches.
Wow.
Yeah. It's where a lot of the motor power for chewing originates and where deep sensation is distributed. So, understanding its boundaries, things like the pterygoid plates medially, the temporal bone superiorly, is absolutely vital for anyone needing to access these structures surgically.
That density of structures, especially the muscles and nerves, leads us nicely to the joint they control. The temporomandibular joint, the TMJ. I mean, think how many times a day we open and close our mouths. It needs to be robust, obviously, but you often hear about TMJ problems, suggesting it's maybe a bit vulnerable.
It is, and its structure is quite unique. The really fascinating thing about the TMJ is that it's not just one joint. Structurally, it's like two separate synovial joints, one above the other, housed within a single joint capsule.
Two joints, how does that work? What separates them?
They're completely divided by an articular disc. It's made of fibrocartilage, quite tough, but also mobile. Think of it like a washer or meniscus that sits between the head of the mandible, the condyle, and the mandibular fossa of the temporal bone above it.
Okay, a disc splitting the joint. Why? What's the functional advantage of having two compartments like that?
It allows for two different types of movement, which are both needed for the full range of jaw motion. It needs to act as a hinge, but also slide forward.
Hinge and slide. Okay, so which movement happens where?
In the lower joint compartment, the space between the mandibular head and the underside of the disc, that's where pure rotational movement occurs. A hinge movement.
Like when you just slightly open your mouth.
Exactly. That initial small opening, maybe to take a sip of a drink,
Yeah.
that's primarily rotation in the lower compartment.
But if you need to open really wide, like for a big yawn or biting into an apple?
You need more than just a hinge. The jaw needs to move forward. That forward sliding movement is called translation or gliding. And that happens in the upper joint compartment, between the top surface of the disc and the temporal bone above it.
Ah, I see. So the head of the mandible and the disc itself glide forward together onto a little bony bump called the articular tubercle.
Precisely. So wide opening involves both the initial rotation in the lower joint and then this anterior translation or gliding in the upper joint. It's a coordinated sequence.
It makes sense then why it might be prone to issues. That gliding part sounds like it could, well, slip. What? If you've ever felt the click in your jaw during a big yawn.
That clicking is often related to the disc. We generally talk about four main types of movement for the mandible, don't we?
Yeah, the basics are elevation, which is closing the mouth.
And depression, opening it.
Then there's protrusion, thrusting the jaw forward.
And retraction, pulling it back.
But there's also side-to-side movement, isn't there, for grinding food?
Absolutely essential for chewing, for mastication. And those lateral movements are complex. To move your chin to, say, the right, the muscles on the left side, particularly the pterygoid muscles, have to contract to pull that side forward slightly, while the right joint acts more like a pivot point. It requires intricate coordination.
So back to the clicking. What's actually happening when someone has a TMJ disorder and they hear that click? Is the disc out of place?
Often, yes. A common issue is anterior displacement of the disc. The disc slips forward relative to the mandibular head when the mouth is closed. Okay. Then, when you start to open, the mandibular head has to slide forward and essentially jump back onto the posterior edge of the displaced disc. That jump, that relocation, is often what causes the initial click.
The recapture click.
Exactly. And then, as you close your mouth, the head might slip back off the disc again, causing a second click. That's called reciprocal clicking. It's basically the sound of that instability, the head moving on and off the displaced disc. It signifies a problem with that smooth, coordinated hinge and slide mechanism.
Right, that makes sense. And speaking of the power behind those movements, let's talk about the muscles responsible. The muscles of mastication, they're incredibly strong, aren't they? Allowing us to bite down with significant force.
They really are. There are four primary muscles of mastication on each side, and importantly, they're all innervated by the same nerve. The mandibular nerve, which is the third division of the trigeminal nerve, CNV3.
And those four are?
The temporalis, the masseter, and then the two deeper ones, the medial pterygoid and the lateral pterygoid.
Okay. And their main job is basically opening and closing the jaw. Or is it more nuanced?
It's mostly about elevation, closing the jaw, and then coordinating those grinding and protrusion retraction movements. The main power for closing, for biting down hard, comes from the two big superficial muscles you can actually feel.
The masseter and the temporalis.
Exactly. The masseter is that thick muscle on the side of your cheek below the zygomatic arch. The temporalis is the fan-shaped muscle filling the temporal fossa. They are the real heavy hitters for elevation. The temporalis also plays a key role in retraction, pulling the jaw backward.
Okay, so they provide the main clamping force. What about the deeper ones, the pterygoids?
They are crucial for the more complex movements. The medial pterygoid works alongside the masseter to help with elevation, but it's also very important for the side-to-side grinding motion.
And the lateral pterygoid, that one seems to get special mention.
It does, and for good reason.
Yep.
It's unique among the four.
How?
Well, firstly, it's the primary muscle responsible for protruding the jaw, pulling it forward. And critically, it's the only one of the main four masticatory muscles that actively helps to open the mouth, to depress the mandible.
Really? I thought gravity did most of the work for opening.
Gravity definitely helps, as do some muscles under the chin, the suprahyoids. But the lateral pterygoid actively pulls the mandibular head and the articular disc forward and slightly downward, initiating that opening movement and the translation phase we discussed.
That's interesting. Does that have clinical relevance?
Oh, definitely. For instance, you have certain types of jaw fractures. The unopposed pull of the lateral pterygoid on the fractured segment can make it really difficult to get the bones lined up correctly for healing. It's constantly trying to pull that piece forward. So yes, its unique action as an opener and protruder is very significant.
Okay, that makes sense. Now, all this powerful muscle action needs a serious blood supply. You mentioned the maxillary artery earlier in the infratemporal fossa. Is that the main supplier here?
It absolutely is. It's a major branch, one of the terminal branches, actually, of the external carotid artery. It arises behind the neck of the mandible and dives deep.
And it supplies pretty much everything in that deep space.
A huge amount, yes. To make sense of its complex branching pattern, anatomists usually divide it into three parts, based on its relationship to that key muscle we just discussed, the lateral pterygoid muscle.
Okay, three parts relative to the lateral pterygoid. Can we walk through those? Because this artery network seems critical not just for function, but also for potential surgical complications.
Let's do it. The first part, sometimes called the mandibular part, runs medial to the neck of the mandible, kind of deep or proximal to the lateral pterygoid.
What branches come off here?
It gives off branches to the ear, the TMJ. But the most clinically significant branch from this first part is the middle meningeal artery.
Ah, the middle meningeal. We've talked about that one before in the context of head injuries.
Exactly. It ascends through a small hole in the base of the skull, the foramen spinosum, and spreads out on the inner surface of the skull bones to supply the dura mater, the tough outer covering of the brain, and the bone itself.
And a fracture, particularly to the side of the head, the genitorian region, can tear this artery,
Leading to an epidural hematoma, a rapidly expanding bleed between the dura and the skull, which is a neurosurgical emergency because it compresses the brain. So a branch originating way down here near the jaw has major implications inside the skull.
Okay, that's the first part. What about the second?
The second part, or pterygoid part, usually runs superficial to the lateral pterygoid muscle, though sometimes it can pass deep to it. This part is all about feeding the muscles.
The muscles of mastication.
Yes, it gives off the masseteric artery, deep temporal arteries, pterygoid branches, basically providing the fuel for those powerful chewing muscles we just talked about. It's the engine's fuel line, if you like.
Makes sense. Powerful muscles need a dedicated supply. And then the final, third part, where does that go?
The third part, the pterygopalatine part, dives even deeper. It passes between the heads of the lateral pterygoid muscle and enters a complex space called the pterygopalatine fossa.
Okay, and its branches supply.
Structures beyond the immediate jaw area. Things like the upper teeth, via the posterior superior alveolar artery, parts of the orbit in the face, via the intraorbital artery, and critically the nasal cavity via its largest terminal branch, the sphenopalatine artery.
The sphenopalatine artery, isn't that often implicated in severe nosebleeds?
It is indeed. It passes through the sphenopalatine foramen into the back of the nasal cavity and is a major supplier there. So you can see this one artery, the maxillary, covers a huge territory, jaw muscles, teeth, dura, nasal cavity, parts of the face. It's a really vital vessel.
It really ties a lot of these regions together. And just to complete the neurovascular picture, we mentioned the mandibular nerve, CNV3, innervating the muscles. What else does it do? It's sensory too, right?
Yes, it's a mixed nerve. It's the largest division of the trigeminal, CNV. Its motor component, as we said, handles the four main muscles of mastication, plus a few smaller ones like the tensor villi palatini, we'll get to that with the palate, and the anterior belly of the digastric muscle.
And the sensory part.
It provides general sensation, touch, pain, temperature to a large area. The skin over the mandible, the side of the head and the temporal region, the inside of the cheek, the lower teeth and gums via the inferior alveolar nerve.
Which is the nerve dentists aim for when numbing the lower jaw.
Exactly, the inferior alveolar nerve block.
Yeah.
And V3 also provides sensation to the floor of the mouth, and importantly, the anterior two-thirds of the tongue for general sensation, not taste, that's different. So it's absolutely essential for feeling food in your mouth, detecting if something is too hot or sharp, as well as controlling the chewing itself.
Okay, that's a great overview of the machinery, the muscles, nerves, and vessels. Let's move inside now, into the oral region itself, the mouth.
Right, the oral cavity, it's the entrance to the digestive tract, obviously, but also key for respiration and speech. We usually divide it into two parts.
Two parts.
Yes, there's the oral vestibule, which is the space outside the teeth and gums, but inside the lips and cheeks, like where you might hold mouthwash before spitting it out.
Okay, the vestibule and the other part.
That's the oral cavity proper. This is the main space inside the arches of the teeth. Its roof is the palate. Its floor is largely occupied by the tongue and underlying muscles, and it extends back to the oropharynx.
And the boundaries, the lips and cheeks, they're more than just skin, right? They have muscles within them.
Oh yes, they're quite complex muscular structures. The lips contain the orbicularis oris muscle, which acts like a sphincter to close the mouth. The cheeks has the buccinator muscles.
The buccinators. They're important for chewing.
Very important. They compress the cheeks against the teeth, keeping food pushed onto the chewing surfaces and preventing it from accumulating in that vestibule space we just mentioned. They work constantly with the tongue to manage the food bolus.
And lining the jaws, holding the teeth, are the gingivae, the gums. You mentioned them in relation to sensation from CNV3. They seem quite specialized.
They are. They need to be tough, but also provide a seal around the teeth. We typically distinguish between two types.
Okay.
There's the gingiva proper, or attached gingiva. This is the firm, pale, pink, often stippled-looking tissue that's tightly bound down to the periosteum of the alveolar bone underneath. It's covered in keratinized epithelium, making it resistant to the friction of chewing.
Built for toughness. And the other type.
That's the alveolar mucosa. It's the looser, shiny, reddish tissue that starts with the attached gingiva ends and continues down into the vestibule. It's non-keratinized and much more mobile. You can see a clear line, the mucogingival junction, separating the two.
And dentists look closely at that line and the health of the attached gingiva, right?
Absolutely. The condition of the gingiva, its color, texture, whether it bleeds easily, tells you a lot about periodontal health. That firm attachment is crucial for protecting the underlying tooth roots and bone.
Which brings us to the teeth themselves, central to this whole region's function. We start with baby teeth and end up with permanent ones.
Yes, we have 20 deciduous teeth, or primary teeth, which typically erupt between 6 months and 2 years of age. These are eventually replaced by 32 permanent teeth, usually starting around age 6.
And these permanent teeth incisors, canines, premolars, molars, they're designed for different jobs, cutting, tearing, grinding. But structurally, they all share a basic plan, right?
They do. Each tooth has a crown, which is the part visible above the gum line, and one or more roots, which anchor the tooth into its socket in the alveolar bone.
And the layers making up the tooth.
The crown is covered by enamel. This is the hardest substance in the entire human body, incredibly mineralized to withstand biting forces.
Harder than bone.
Much harder. Beneath the enamel, forming the bulk of the tooth, is dentine. It's also hard, yellowish, but not as brittle as enamel. It has microscopic tubules running through it, which is relevant for sensitivity.
Okay, enamel, then dentine. What's at the core?
The pulp cavity. This is the central space containing the living tissue of the tooth connective tissue, blood vessels, and nerve fibers. It extends down into the root canals.
And root itself is covered by
Cementum. It's a bone-like tissue that covers the dentine of the root and helps anchor the tooth into the socket via the periodontal ligament.
So the nerve and blood supply get in through the tip of the root.
Yes, through a tiny opening at the very apex of each root, called the apical foramen. That's the lifeline for the pulp tissue.
That seems like a potential bottleneck if things go wrong, like with an infection.
It is indeed. We'll come back to that when we discuss clinical issues.
One more thing about the teeth, their sockets, the dental alveoli. The bone holding them in isn't uniform, is it? I remember reading something about that affecting extractions.
That's a very important clinical point. The alveolar bone, the bone that directly supports the teeth, is constantly remodeling, and its thickness varies.
How so?
For the front teeth, the incisors, the bone on the outer side, the labial or lip side, is often quite thin, whereas the bone on the inner lingual or tongue side is thicker.
So if you need to extract an incisor.
It's often easier, or sometimes necessary, to fracture or remove some of that thin labial bone to get access to the root.
And it's different for back teeth.
Often, yes. For molars, especially lower molars, the lingual plate of bone might be thinner than the buccal cheekside plate. So the surgical approach might be adjusted based on which wall of the socket is weaker. Understanding that variation in bone thickness is crucial for safe and effective dental surgery.
Okay, great detail on the teeth and gums. Let's move to the roof of the mouth now, the palate.
The palate. It's the structure that separates the oral cavity below from the nasal cavities above, essential for breathing while eating and for speech.
And it has two distinct parts, doesn't it?
It does. The anterior two-thirds is the hard palate. It's bony, rigid, formed by parts of the maxillae, the palatine processes, and the horizontal plates of the palatine bones further back. You can feel it with your tongue.
Right, it provides a firm surface for the tongue to work against during chewing, and the posterior part.
The posterior one-third is the soft palate. It's muscular, mobile, and kind of hangs down at the back, ending in that little teardrop structure, the uvula.
So hard palate is bone, soft palate is muscle. Let's focus on the hard palate first. What nerves and vessels are important there?
The main supply comes through foramen, little holes in the bone at the back of the hard palate. The largest is the greater palatine foramen, located usually just behind and medial to the last molar tooth.
Okay.
Emerging from this foramen are the greater palatine nerve, a branch of CNV2, the maxillary nerve, and the greater palatine artery from the maxillary artery. These then run forward on the underside of the hard palate, supplying the mucosa, glands, and gingiva of most of the hard palate.
So sensation and blood supply for the roof of the mouth primarily come from the back and run forward. Are there others?
Yes, there are usually smaller, lesser palatine foramina just behind the greater one. These transmit the lesser palatine nerves and vessels, which supply the soft palate region.
Okay. Now moving to that soft palate. You said it's muscular and mobile. What's its main job?
It acts like a valve. Its primary function is to move upward and backward during swallowing.
To close off the connection to the nasal cavity.
Precisely. It elevates to seal off the nasopharynx, the part of the throat behind the nose, preventing food or liquid from going up into the nasal cavity when you swallow. It also tenses to help with swallowing and speech articulation.
And this movement is controlled by muscles. How many?
There are 5 pairs of muscles that contribute to the function of the soft palate. They have rather descriptive names like levator veli palatini, which lifts the palate, tensor veli palatini, which tenses it, palatoglossus, palatopharyngeus, and the musculus uvulae within the uvula itself.
5 pairs. And the nerve supply to these must be coordinated perfectly for swallowing to work. Is it all one nerve?
Interestingly, no. This is where it gets a bit intricate again, reflecting different functional controls. Most of the soft palate muscles, the levator veli palatini, palatoglossus, palatopharyngeus, musculus uvulae, are innervated by the pharyngeal plexus.
The pharyngeal plexus. That involves contributions mainly from the vagus nerve, CNX, right?
Primarily, yes, with some fibers from the glossopharyngeal nerve, CNIX, as well. But there's one exception.
Which one?
The tensor veli palatini. This muscle, responsible for tensing the palate, is innervated by the mandibular nerve, CNV3, just like the muscles of mastication.
That's fascinating. Why the split? V3 controlling the tensor, vagus mostly controlling the elevators and shapers.
It likely reflects different developmental origins or functional roles. Tensing the palate might be more closely linked, functionally or embryologically, to the mechanics of opening the eustachian tube, which the tensor also helps with, and maybe even mastication, hence the V3 connection. Whereas the lifting and sealing action for swallowing is more aligned with other pharyngeal functions controlled by the vagus nerve.
It really shows the complexity of coordinating something we do without thinking, like swallowing.
Absolutely. And remember, sensation for the entire palate, both hard and soft, comes largely from CNV2, the maxillary nerve, via those greater and lesser palatine nerves we mentioned. So you have V2 for sensation, V3 for tensing, and vagus pharyngeal plexus for most of the movement. It's a finely tuned system.
It really is. And given how much is packed in here and how complex the coordination needs to be, it seems inevitable that things can go wrong. Let's circle back and focus on some of the key clinical vulnerabilities you've touched upon, maybe starting with the parotid gland again.
Okay. We mentioned the intense pain from swelling due to the tough parotid sheath, like in mumps. Another common issue is the formation of siloliths, or salivary stones, within the parotid duct system.
Stones blocking the duct.
Exactly. These are calcified deposits. If one lodges in the main parotid duct, Stenson's duct, it blocks the outflow of saliva.
Which would cause pain when?
Classically, the pain gets much worse during meals or even just thinking about or smelling food, especially something acidic like a lemon,
Because that stimulates saliva production.
which then builds up behind the blockage, causing the gland to swell painfully. It's quite a characteristic symptom pattern.
Right. Okay, moving from glands to joints. The TMJ. We talked about clicking and displacement. What about full dislocation?
TMJ dislocation is actually relatively common. It usually happens when the mouth is opened extremely wide, maybe during a huge yawn, laughing fits, or sometimes from a blow to the chin when the mouth is open.
And what happens is it slip forward?
Yes, it's almost always an anterior dislocation. The head of the mandible glides so far forward over that articular tubercle we mentioned.
That it gets stuck in front of it.
Precisely. It becomes lodged anterior to the tubercle and can't slide back into the fossa. The muscles, especially the elevators like the masseter and temporalis, then often go into spasm, which locks the jaw in that open, dislocated position. The person can't close their mouth.
That sounds alarming. How is it fixed?
It usually requires manual reduction by a clinician, sometimes with muscle relaxants or sedation. They need to carefully maneuver the mandible downward and backward to get the head back over the tubercle and into the fossa. It's also important to note that sometimes a severe blow causing dislocation can also cause a fracture of the neck of the mandible on that side.
Okay. Now, let's revisit something you mentioned much earlier relating to arteries, but it had a rather dramatic name, the corona mortis. That wasn't directly in the TMJ or parotid region, was it?
No, it's actually related to the obturator artery down near the pelvis, but it involves a branch of an artery we did discuss higher up. The external iliac artery gives off the inferior epigastric artery, which is relevant here.
Okay, refresh my memory on this connection and the risk.
Right. The obturator artery normally supplies structures in the thigh. However, in about 20% of people, there's a significant anatomical variant. An enlarged pubic branch arising from the inferior epigastric artery, which itself comes off the external iliac, runs across the pelvic brim. This variant vessel either replaces the normal obturator artery or joins it, an accessory obturator artery.
And the problem is where this variant artery runs.
Exactly. It often runs very close to or even directly across the edge of the femoral ring. This is the opening where femoral hernias occur, more commonly in women.
Ah, I see the danger. Surgery for a femoral hernia.
Could easily lead to accidental laceration of this variant artery if the surgeon isn't aware of it or can't see it clearly. Because it can be quite large and is under arterial pressure, nicking it can cause severe, potentially fatal hemorrhage right there at the top of the thigh.
Hence the name corona mortis, the crown of death.
Indeed. It highlights the critical importance of knowing about common anatomical variations, especially in surgically vulnerable areas. Preoperative imaging or extreme care during dissection is needed.
That's a stark reminder. Okay, let's shift back into the mouth itself. Dental problems are incredibly common. You mentioned caries or cavities. What happens when decay gets really deep?
If dental caries isn't treated, the bacterial decay process eats through the enamel, then the dentine, and eventually reaches the pulp cavity at the center of the tooth.
Where the nerves and blood vessels live.
Right. When bacteria invade the pulp, it triggers inflammation pulpitis.
And we talked about the pulp cavity being a rigid space.
Exactly. Just like the parotid gland in its sheath, the inflamed pulp tissue swells within that confined, hard-walled pulp cavity. The pressure builds up rapidly, compressing the nerve endings.
Causing that intense, throbbing toothache.
Yes, often described as spontaneous, severe, and unrelenting pain. And because the blood vessels entering through that tiny apical foramen are also compressed by the pressure.
The blood supply gets cut off.
It can, leading to necrosis, or death, of the pulp tissue. The infection then doesn't just stay in the pulp. It tracks down through the root canal, out the apical foramen, and into the surrounding bone and soft tissues at the root tip.
Leading to an abscess.
A dentoalveolar abscess, a collection of pus forms, causing more swelling, bone destruction, and pain. It can sometimes spread into adjacent fascial spaces in the face or neck, which can be serious. Treatment involves draining the infection, usually by opening into the pulp cavity, root canal treatment, or extracting the tooth, and often requires antibiotics. And getting profound anesthesia for these procedures often means targeting that inferior alveolar nerve we mentioned earlier.
It really illustrates that pathway from a small cavity to a potentially significant infection. Finally, let's touch on developmental issues. Cleft lip and cleft palate are quite visible examples of when anatomy doesn't form correctly.
They are. And they represent failures of fusion of different facial prominences during embryonic development, typically between the 6th and 12th weeks.
So different parts don't join up properly. What fails to fuse in a cleft lip?
Cleft lip usually involves a failure of the maxillary prominence on one side to fuse properly with the medial nasal prominences in the middle. This leaves a gap in the upper lip to one side of the midline, unilateral, or sometimes both sides, bilateral. It happens in about 1 in 1,000 births, more often in males, and can range from a small notch to a complete separation extending up into the nostril.
And cleft palate, is that a similar failure of fusion?
It is, but it involves the structures forming the roof of the mouth. It's a failure of the lateral palatine processes, or palatal shelves, to grow towards each other and fuse in the midline. They might also fail to fuse with the nasal septum above or the primary palate at the front.
And this happens slightly less often.
Yes, about 1 in 2,500 births, and it's actually slightly more common in females. The severity can vary greatly, too, from just a cleft in the uvula, bifiduvula, to a cleft involving the entire soft palate or extending right through the hard palate as well, sometimes connecting with a cleft lip.
Creating an open connection between the oral and nasal cavities.
Exactly.
Yeah.
Which causes significant problems with feeding, especially in infants, difficulty suckling, swallowing, food entering the nose, and later on with speech development. Repair usually involves complex surgery.
It's a powerful reminder of how precise those developmental processes need to be. A slight delay or disruption in tissue migration and fusion can have really major lifelong consequences. Every structure we've discussed today, from the TMJ disc to the muscles of the soft palate, had to form through these incredibly intricate steps. #HadCatTakes outro.
So wrapping up, we've really journeyed through the functional anatomy of the face and mouth today. We dissected, conceptually at least, the mechanics of the TMJ with its dual compartments, traced the vital supply lines of the maxillary artery and the mandibular nerve.
Right, and explore the powerful muscles driving mastication, the structure of the teeth and their supporting tissues, and the intricate valve system of the palate.
And critically, we highlighted those points where things often go wrong. The pain of parotid swelling, the risk to the facial nerve, TMJ dislocations, the danger of that corona mortis artery variant, the pathway of dental infection, and the developmental origins of clefts.
It's definitely a dense region anatomically, but I think understanding those tight spaces, the nerve and vessel pathways, and how rigid structures like fascia or tooth pulp cavities can amplify problems, that context is so important for anyone studying or working with human anatomy.
Couldn't agree more. The link between the detailed structure and the clinical presentation is incredibly direct here. Every anatomical detail really does matter, whether you're figuring out why a jaw clicks or planning a safe surgical approach.
Well, next time, we're going to stay in the head region, but shift our focus again. We'll be exploring the complex sensory systems housed within the nose and the ear.
Ah, yes. Delving into the structures responsible for our sense of smell, hearing, and also our sense of balance. Looking forward to it.
Me too. Thanks for listening to Bookfulness.